Today, our lecture about the fundamentals of the intra-aortic balloon pump. And these are our lecture outlines. And this lecture will be divided into three sections. The first section about the physiology behind the intra-aortic balloon pump. And the second section about the indication, contraindication of the intra-aortic balloon therapy, device configuration, mechanism of action of intra-aortic balloon, and hemodynamic effect of intra-aortic balloon pump, and patient assessment during the run of intra-aortic balloon. And the last section about the troubleshooting and complication, weaning of intra-aortic balloon, and the last thing is removal of intra-aortic balloon. And as we know that the intra-aortic balloon is the most commonly used mechanical circulatory support device that has been used for years for the support of the failing heart, especially in cardiogenic shock complicating acute myocardial infarction. And the history of the intra-aortic balloon started in 1961 with preliminary studies about the concept of the intra-aortic balloon. And the concept of the external counterpulsation was introduced by Dennis et al. In 1963. And in 1967, it was the first clinical application of successful treatments with intra-aortic balloon. And in 1970, almost 30 patients have been treated with cardiogenic shock complicating acute myocardial infarction successfully with intra-aortic balloon. And the physiology behind with intra-aortic balloon start with the cardiac cycle. And as we know from the physiology that the cardiac cycle is divided into two phases, both of them at the same time occurring simultaneously, the electrical cardiac cycle and the mechanical cardiac cycle. And as we see from this cartoon that the electrical and mechanical cardiac cycle are occurring simultaneously at the same time. Starting with the electrical cardiac cycle, so the electrical cardiac cycle start with the activation of the SA node, which will initiate propagation of the electrical discharge to the atria, leading to atrial contraction, which is starting with the mid of the P wave till the peak of the R wave. And from the peak of the R wave till the next peak of the peak of the next R wave, this is the time for the atrial diastole. And regarding the electrical ventricular cycle, it starts with the peak of the R wave, where the ventricular systole will start till the end of T wave, where the ventricular diastole will be initiated, and it will end at the peak of the next R wave. So as we see here that the atrial systole is very short and the atrial diastole is the longest one. And the ventricular systole is shorter than the ventricular diastole. And as we see that the ventricular diastole, it will take longer duration. And going to the mechanical cardiac cycle, as we see here, the mechanical cardiac cycle is divided into two systole and the diastole. Systole is a shorter duration, and the diastole is more prolonged. And the systolic mechanical cardiac cycle is divided into two phases, the isovolumetric contraction phase and the ventricular ejection phase. And the diastolic mechanical cardiac cycle is divided into three phases, which is the isovolumetric relaxation phase, ventricular filling phase, and later on the augmentation by the atrial contraction. And these are the different phases of the mechanical cardiac cycle. Simply, it starts here with the closure of the mitral valve with the isovolumetric contraction phase. After that, the aortic valve will start opening, leading to initiation of the ventricular ejection phase. And after that, the aortic valve will close, leading to initiation of the isovolumetric relaxation phase. Then the mitral valve will open, leading to passive filling phase. After that, the atrial contraction will happen, leading to the active phase, initiation of the active phase of the ventricular filling. And again, this is the summary of the mechanical cardiac cycle. There is a systole and the diastole. There is two phases of isovolumetric contraction and isovolumetric relaxation phase. systolic ejection phase, and there is diastolic filling phase. And the mechanical cardiac cycle, as we see here, you will have a lot of changes in the pressure and volume inside the ventricle throughout the different phases of the cardiac cycle. The mechanical cardiac cycle starts here at this point where the mitral valve will start the closure here, and after that the aortic valve will start opening here at this phase. So this short phase is called the isovolumetric contraction phase. And from the initiation of the aortic valve opening till the aortic valve close, this phase is called the isovolumetric contraction phase. And after closure of the aortic valve, and at that time the mitral valve is still closed, this duration where the mitral valve, when after that the mitral valve will start opening to start the filling of the left ventricle, this phase is called the isovolumetric relaxation phase. After opening of the mitral valve, the diastolic filling phase will be initiated in order to fill the ventricle with the blood. So the first phase of the mechanical cardiac cycle is the isovolumetric contraction phase. At this point, it starts by the ECG activity at the peak of the R wave till the end of the QRS complex. So initiated at the peak of the R wave till the end of the QRS complex. And as we see, this phase is very short phase. And at the same time of the peak of the R wave, the mitral valve will start the closure. At the same time, the aortic valve is closed. So at this phase, the mitral valve will start closure while the aortic valve is closed. So the volume inside the heart is the same throughout this phase. That's why they are calling it isovolumetric contraction. At this phase, the mitral valve will close while the aortic valve is closed. So the volume inside the heart will be the same. The heart will start the contraction, so you will notice that the volume will be the same, but the pressure will be increased. As you see here, the heart will start the contraction, so you will see changes in the pressure till it reach here to this point where the aortic valve later on will start opening. And as you see, there is no change in the volume. So this, the blue one, is the changes in the pressure inside the left ventricle, and the red one is the changes in the volume inside the left ventricle. So the isovolumetric contraction phase starts by ECG at the peak of the R wave till the end of the QRS complex. At this phase, the mitral valve will close, so there will be no change in the volume inside the ventricle, while the left ventricle will start the contraction. This will lead to increase in the pressure if in the left ventricle reaching to this point. Going to the next phase, which is the ejection systolic phase, meaning that at this point it start at the end of the QRS complex till the end of the T wave by the ECG. At this phase, the aortic valve will start opening. The ventricle is still contracting while the mitral valve is closed. The aortic valve will start opening. So what will happen here? The blood inside the left ventricle will be ejected to the aorta. So you will notice reduction in the volume of the blood inside the left ventricle in the volume graph. And because the left ventricle is continue to contract for a longer duration, so you will notice that the pressure inside the left ventricle will be increased. As you see here, the systolic ejection phase regarding the pressure changes start at this point where the aortic valve will start opening while the left ventricle is still contracting. So you will notice that increase in the ventricle pressure till it reaches the maximum here, which is the peak systolic pressure. And because the blood inside the left ventricle will be ejected to the aorta, so you will notice that there is reduction of the left ventricle volume till it reach to the minimal, which at the end of the systole, which is called the end systolic volume. So the volume inside the heart at the end of the systole is called the end systolic volume. Going to the next phase, which is the isovolumetric relaxation phase, which starts here at this point where the aortic valve will start a closure. So while at this point the aortic valve will start the closure while the mitral valve is closed. So the same will happen. The mitral valve is closed, the aortic valve will start the closure. So the volume inside the heart will continue to be the same. And at the same time, the left ventricle will start the relaxation. So you will notice that no change in the volume, but because the ventricle starts the relaxation while the valves are closed, so the left ventricle pressure will be reduced. So here the aortic valve will start the closure and the ventricle will start the relaxation. So you will notice that the pressure will drop from this point till this point. And at the same time, because the mitral valve is closed and the aortic valve is closed, so you will notice that there is no change in the volume at this phase of isovolumetric relaxation phase. After that, the mitral valve will start opening, leading to initiation of the diastolic filling phase, where the blood will be directed from the left atrium to the left ventricle. So ideally, you will notice that change in the volume inside the heart at this phase. So here the aortic valve will start, the mitral valve will start the opening, and the volume inside the heart left ventricle will be increased till it reach at the maximum of the end diastole, which is called the end diastolic volume. At this phase, there is minimum change in the pressure inside the left ventricle because this this phase is almost passive phase because there is no contraction inside the left ventricle and there is no contraction from the left atrium. And later on, the left ventricle will start the contraction, leading to active phase of the ejection from the blood of the blood from the left ventricle, left atrium to the left ventricle. So this is the latest phase of the mechanical cardiac cycle. And throughout the mechanical cardiac cycle, we can plot the changes of the left ventricle pressure against the time. So you will get the left ventricle pressure time curve. And here, as we see, this phase is the isovolumetric contraction phase, and this phase is the systolic ejection phase, and this phase is the isovolumetric relaxation phase, and after that, the ventricular filling phase during the diastole. Here, the mitral valve will start the closure. After that, the left ventricle will start contraction in the isovolumetric contraction phase. So you will get rise of the pressure from this point to this point, where the aortic valve will open. The left ventricle will continue to contract, so the pressure will continue to rise till it reach to the maximum here during the ejection systolic phase, which is called the peak systolic pressure. After that, here at the end of the ejection systolic phase, the aortic valve will close and the left ventricle will start the relaxation at the same time of mitral valve closure. So there will be marked drop of the pressure from the this point to this point during the isovolumetric relaxation phase. After that, the mitral valve will open here, leading to initiation of the diastolic filling pressure, diastolic filling phase. So these are the changes of the pressure throughout the cardiac cycle in relation to the changes of the mitral and aortic valve opening and closures. And the same we can do for the left ventricle volume throughout the cardiac cycle. This is the isovolumetric contraction phase, ventricular ejection phase during the systole, and isovolumetric relaxation phase, and the remaining is the ventricular filling phase. And as you see, during the isovolumetric contraction phase, there is no change in the volume. And during the ejection systolic phase, you will notice reduction of the volume inside the left ventricle to the minimum, which is the end systolic volume. After that, the isovolumetric relaxation phase will be initiated, and there is no change in the volume in this one because mitral and aortic valve are closed. After that, the mitral valve here at this point will start the opening, and the left ventricle filling will start, leading to increase of the ventricle volume, which will reach to the maximum here at this point, which is the phase of the end diastolic volume. And here you see this point, you will find the end diastolic volume. And here at this point, this is the end systolic volume. The difference between the end diastolic volume and the end systolic volume is equal to the stroke volume. Again, this is the left ventricular pressure time curve, left ventricle volume time curve. If you are able to plot both curves against each other, you will get the left ventricle pressure volume curve. So to understand the left ventricle pressure volume loops, so here you will get here, this is the beginning of the cardiac cycle. At this phase, this is the end of the diastole, where the mitral valve will start the closure and the left ventricle will start the isovolumetric contraction phase. So you will notice that no change in the volume, but the pressure will be increased from this point till this point. At this point, the aortic valve will start the opening and the heart will start the ejection systolic phase, where the pressure will reach to the maximum, which is the peak systolic pressure. And after that, the aortic valve will close, leading to initiation of the isovolumetric relaxation phase. You will not notice any change in the volume, but the pressure will markedly drop to this point at the end of the isovolumetric relaxation phase. And after that, the mitral valve will start opening here, leading to initiation of the diastolic filling. And you will notice that there is minimally change in the pressure here, but the volume will increase from this point to this point. So at this point, this is the end diastolic volume, and this one is the end systolic volume. So the difference between this point and this point is equal to the stroke volume that has been ejected by the heart with each cardiac cycle. And you will find that there is two points here, very important points, this point and this point. This point is the describes the relationship between the pressure and volume at the end of the diastole, which is called the end diastolic pressure volume relationship, which is a surrogate of the preload state of the heart. And this point describes the relationship between the pressure and volume relationship of the left ventricle at the end of the systole, which is called the end systolic pressure volume relationship, or Emax, which is a surrogate of the left ventricle afterload, and also is a surrogate of the left ventricle contractility. So if this point has been moved from this point to this point, you will notice that there is a reduction of the stroke volume and the cardiac function has been depressed. But if this point has been moved up, that means the afterload of the left ventricle has been increased. And if this point at the end of the distole, if the end of the diastole has been moved to the right, to this point, that means the end diastolic volume and the end diastolic pressure has been increased, meaning that the preload state of the heart has been increased. And the most important is the left ventricle pressure volume loops, especially in cardiogenic shock. So this is the steady state of normal functioning heart. And this is the pressure volume loops of a patient with the cardiogenic shock after acute myocardial infarction. And this is the left ventricle pressure volume loops in a patient with cardiogenic shock and started to be dilated. So here you notice that in acute myocardial infarction, there is minimally change in the preload state of the heart, but you will notice that the Emax, or the end systolic pressure volume relationship, has been dropped from this point till this point. That means that the systolic function of the heart has been reduced, and as you see, the difference between this point and this point is equal to the stroke volume, which is reduced from this point to this point. And in case of cardiogenic shock, you will notice that there is a change of the cardiac function markedly, and also the change of the diastolic function, and the preload state of the heart moved from this point till this point, and the cardiac systolic function dropped from this point to this point. Again, this is the pressure volume loops of the left ventricle in case of acute heart failure and chronic heart failure. The same also, you will find the drop in the systolic function gradually till it reaches the chronic stage, and the preload state is markedly progressively deteriorating. And these are the pressure volume loops of a patient with increased preload status. So this is a normal heart, and the end diastolic volume and diastolic pressure here. So move to the right side to this point. That means the preload state of this patient has been increased, but the systolic function is still the same. And these are the left ventricle pressure loops of a patient with increased afterload. So here you will notice that the end diastolic volume and end diastolic pressure are the same. So the preload state is still the same. But as you see here, this point has been displaced from this one to this one, meaning that the afterload has been increased. Increase of the afterload will lead to reduction of the stroke volume. See the stroke volume here in the first curve is normal, and the stroke volume here is decreased secondary to increase of the afterload of the left ventricle. The next section of this lecture is about the coronary perfusion. And as we know from the physiology, the heart is divided into the right ventricle and the left ventricle. And regarding the right ventricle perfusion, the coronary perfusion of the right ventricle happened during the systolic and the diastolic phase. And the left ventricle perfusion is happening mainly during the diastolic perfusion. And this is the left ventricle perfusion, the coronary blood flow plotted against the time throughout the cardiac cycle. This is the systolic phase, and this is the diastolic phase. And as you see, the perfusion of the left ventricle, the flow is mainly happening during the diastole, with minimal contribution of the coronary flow during the systolic phase. Compared to the right ventricle perfusion, uh, the perfusion is mainly happening during the systole, and also happening equally during the diastole. So it's very important that in case of RV failure, you have to maintain the systolic blood pressure and the diastolic blood pressure in order to maintain the diastolic and systolic coronary perfusion of the right ventricle. And here the left coronary artery and right coronary artery perfusion plotted against each other against the time throughout the cardiac cycle. As you see, the right coronary is perfused throughout the cardiac cycle. Left coronary is mainly perfused during the diastolic time. And here also, this is the left coronary blood flow, and this is the aortic flow. The coronary flow here is happening mainly during the diastolic phase, and here the coronary flow is very less during the systolic phase. And back to the morphology of the arterial waveform. As you know, the arterial waveform, there is the anacrotic limb and there is the diacrotic limb. The anacrotic limb starts here with ejection of the blood from the left ventricle to the aorta, leading to reach to the maximum here at the peak systolic pressure. And it will end, the systolic phase will end at the diacrotic notch, where the aortic valve will start the closure, leading to initiation of the diastole. So this is the diastolic area, the area under diastolic curve. And the arterial waveform is divided into two phases. The first phase is called the systolic pressure time index, and the diastolic pressure time index. The diastolic pressure time index is the area under diastolic curve measuring the pressure inside the ventricles, inside the aorta. The systolic pressure time index is a surrogate of the workload of the heart. The heart has to perform the ejection of the heart has to perform work to work against the aorta in order to inject the blood, and this equal to the myocardial oxygen demand. And here, during the diastolic phase, the pressure should be maintained in order to maintain the coronary filling. So this area under curve is a surrogate of the coronary perfusion, and also is a surrogate to the coronary blood supply or oxygen supply. So this phase is equal to the oxygen demand, and this phase is surrogate to the oxygen supply to the heart throughout the cardiac cycle, through the systolic phase and throughout the diastolic phase. And if you divided the diastolic perfusion time index over the systolic pressure time index, you will get what is called subendocardial viability ratio. The subendocardial viability ratio is a surrogate of the coronary perfusion of the heart, especially of the left ventricle. If the ratio is high, that means the coronary perfusion is getting adequate flow. And if the ratio is low, that means the coronary perfusion is impaired. So if we plotted the changes of the coronary perfusion in relation to the systolic perfusion time index and diastolic perfusion time index, you will notice that this is the subendocardial coronary flow. You will notice that the subendocardial coronary flow is related to mainly due to the diastolic perfusion time index. So if you are able to increase the area under curve of the diastolic perfusion time index, you will be able to increase the coronary blood supply, which will increase the oxygen supply to the heart. And to understand this is a normal patient with adequate coronary perfusion, with normal diastolic perfusion time index. And this is a patient who is to be known to be hypertensive, with heart failure and increased aortic stiffness. And as you see, the diastolic perfusion time index is less than this compared to this patient, and the same also the coronary perfusion here compared to this one is reduced. So if you are able to increase the diastolic perfusion time index, the area under curve, so you will be able to increase the coronary perfusion. And this is the concept of the intra-aortic balloon, because the intra-aortic balloon will increase the area under curve of the diastolic perfusion time index, because it will start inflation during the diastole, and it will be able to maximize the area under curve in order to maximize the coronary blood flow. As we see here, this is a patient without intra-aortic balloon. So here, this is the tension time index, or what is called the systolic pressure time index. And this area, this is the diacritic notch, this is the area under diastole, diastolic pressure time index. And this wave is assisted with the intra-aortic balloon. And as you see, the area under curve here is compared to this one is much less, and the intra-aortic balloon is able to increase the area under curve of the diastolic perfusion time index, so you will be able to increase the subendocardial blood flow. Going to the next section of the physiology behind of the intra-aortic balloon, so we have to understand what is called the arterial Windkessel effect. And the arterial Windkessel effect is simply meaning that if your heart is able to contract only during the systole, that means it will eject the blood to the aorta only during the systole, which means that you will be able only to get a blood flow only during the systole. So what will happen during the diastole? You will not be able to get a continuous blood flow during the diastole because the heart is not ejecting. But this is not happening in the reality. So what happened in the reality is that the left ventricle will start the contraction, and the aortic valve will start opening, and the blood will be ejected from the left ventricle to the aorta distally, and the part of the blood will be stored in the wall of the aorta, because the aorta is having the characteristic of the blood vessels, which is the ability of distensibility and also the ability of the elastic recoil. So part of the blood ejected by the heart will be directed to the distal organs. Almost 50% of the blood flow will be directed to the distal organs, and the other 50% it will be stored in the wall of the aorta, because the aorta is very compliant and distensible. Later on, during the ventricular relaxation, where the ventricle will start relaxation, the aortic valve will start the closure. Then what will happen here? There is no blood supply going to the distal organs, but the blood stored in the wall of the aorta will the aorta will start the elastic recoil, and the blood will be directed to the distal organs during the diastole. Like that, you will get continuous blood flow throughout the cardiac cycle. During the systole, the blood will be ejected from the heart to the distal perfusion, and during the diastole, the blood that was stored in the wall of the aorta will be directed to or be displaced to the distal organs during the diastole, so you will get continuous blood flow throughout the cardiac cycle. And if we lost the elasticity and the aorta become stiff, so you will not be able to achieve the diastolic flow. And we see in this cartoon that this is a stiff tube that has been connected to a pump, which will eject the blood during the systole only. So what you will get here is you will get only flow during the ejection of the blood, but during the diastole, you will not get any flow, as you see here. So what you see here is that you are not getting continuous blood flow. You are getting flow only during the systole, because the tube is stiff and is not compliant, is not able to distend in order to store the blood in the wall and to eject the blood during the elastic recoil during the diastole. So what will happen? So what will happen if we added elastic part to the tube? You will be able to get continuous blood flow, as you see here. So as you see here, adding the elastic bars to the circulation is able to give the state of the continuous blood flow throughout the cardiac cycle, through the systole and through the diastole, and this is what we are calling the Windkessel effect. And the intra-aortic balloon is able to maximize the arterial Windkessel effect, because the intra-aortic balloon will be inflated during the diastole, and it will augment the displacement of the blood to the brain and to the heart and to the distal perfusion organs during the diastole. So, and when the intra-aortic balloon will start the deflation, so the heart will start to eject the blood to the organs during the systole. And during the diastole, the intra-aortic balloon will start the inflation, leading to displacement of the blood to the brain, to the coronaries, and also to the distal organs. And this that we are calling the maximization of the arterial Windkessel effect by the intra-aortic balloon. Going to the next section, which is the mechanism of action of the intra-aortic balloon. The mechanism of action of the intra-aortic balloon. The balloon is designed to sit in the proximal part of the descending aorta. This part of the descending aorta, there is no blood supply to major organs, so the balloon will sit here, and the balloon, when will be inflated, it will almost occlude around 80 to 90% of the aortic diameter. And when the balloon will start the inflation, okay, so the balloon will start inflation during the diastolic phase, which is almost at the mid or at the end of the T wave, the balloon will start the inflation. This is the balloon pressures, and these are the inflation phase. This is the inflation phase, the plateau phase of the inflation. So the balloon will start the inflation here. And as you see, the morphology of the arterial waveform, instead of being like this, the area under the diastolic curve, it will be increased. This will increase the main arterial blood pressure, and also the diastolic perfusion time index will be increased, so it will increase the coronary blood flow. So the balloon will start the inflation during the diastole, and the balloon will start the deflation during the the systole, which is called the counterpulsation concept. And as we see here in this cartoon, during the diastole, the balloon will inflate, and during the systole, the balloon will start the deflation. Here, as we see, during the balloon inflation, this will lead to, in the upper half of the body, this will lead to displacement of the blood to the upper limbs, to the brain, and to the coronary. So it will maintain the organ perfusion during this phase, and distally, it will increase the blood flow to the kidney and also to the distal organs. And what will happen during the balloon deflation, which is during the systole, the balloon deflation, it will create negative pressure inside the aorta, and this will create a vacuum, and this will decrease the afterload of the heart, and also it will help the failing heart in order to eject the blood during the systolic phase. So this is the mechanism of action of the intra-aortic balloon. So during the balloon inflation, the balloon, it will inflate at the onset of the diastole when the aortic valve starts the closure. So inflation of the balloon will lead to displacement of the blood, which will increase the aortic pressure during the diastolic time. And the benefit of that, it will increase the main arterial pressure, it will increase the cerebral blood flow, and it will increase the coronary blood flow. During the balloon deflation outwork, it will deflate just prior the initiation of the systole, where the aortic valve, before opening of the aortic valve. The intra-aortic balloon deflation result in rapid decrease in the intra-aortic pressure. This will create a negative pressure. This will lead to reduction of the afterload, and this will lead also improvement of the cardiac output, improvement of the stroke volume with each cardiac cycle, and this reduction of the left ventricle afterload and improvement of the cardiac output. And also, the balloon is able to increase the left ventricle end diastolic volume and a left ventricle end diastolic pressure, and this will decrease the cardiac workload and also will decrease the oxygen demand by the heart. As we know from the arterial waveform morphology, there is a necrotic limb and diacrotic limb, and this is the diacrotic notch, big systolic pressure, systolic upstroke, systolic phase, and diastolic phase. And what will happen during the, this is the normal morphology of the arterial waveform, and this will be the morphology of the arterial waveform with the augmentation or assist of the intra-aortic balloon. So you will get the, here, the beginning of the cycle, so you will get unassisted end diastolic pressure, then systolic upstroke, then you will reach here to the unassisted systolic pressure, then systolic decline, then you will reach to the diacrotic notch. Just prior to the diacrotic notch, the inflation point will happen here, where the balloon will start the inflation, leading to augmentation of the diastolic blood pressure, which is called diastolic augmentation. And the peak of the diastolic augmentation, ideally, it should exceed the peak of the unassisted systolic pressure. And after some time, the intra-aortic balloon, so inflation of the balloon will stay for some time. Then with the beginning of the systole, the intra-aortic balloon will start the deflation. Deflation of the intra-aortic balloon will decrease or drop the pressure inside the aorta. So you will get what is called assisted end-diastolic pressure. And the assisted end-diastolic pressure ideally it should be less than the unassisted end-diastolic pressure. And also the next wave is the systolic upstroke, and you will get the peak here, which is called the assisted systolic pressure. And the assisted systolic pressure and the assisted end-diastolic pressure will be less than the assisted systolic pressure and the assisted end-diastolic pressure. So the assisted systolic pressure should be at lower level than the unassisted systolic pressure, and the assisted end-diastolic pressure should be at lower level than the unassisted end-diastolic pressure. So this is the IABP for morphology and terminology. So what is before the balloon augmentation is called unassisted pressure waveform, and after the balloon inflation, what is called the assisted pressure waveform. And what are the hemodynamic effect of the intra-aortic balloon? You will get changes in the systolic events, and you will get changes during the diastole. You have changes in the coronary blood flow and also changes in the cerebral blood flow. Regarding the changes in the systolic phase, so you will get a decrease in the systolic blood pressure. So, which means that, as we said, the assisted systolic pressure will be decreased, and also the left ventricle, which will lead to reduction of the left ventricle afterload. And during the systole, reduction of the afterload, it will improve the left ventricle stroke volume, because the resistance against the failing left ventricle, it will be reduced. So the left ventricle will be able to improve the stroke volume by ejecting more blood. And during this systolic phase, because of reduction of the afterload, so the left ventricle workload will be decreased and the left ventricle oxygen demand will be decreased. Changes during the diastolic event, so the area under curve of the diastole will be increased, so this will increase the main arterial blood pressure, and also this will increase the augmented pressure, which also will increase the perfusion to the organs, and the left ventricle and the diastolic pressure and left ventricle and the diastolic volume will be reduced. Why the left ventricle and the diastolic pressure will be reduced? Because during the augmentation, of the intra-aortic balloon, after that you will get rapid deflation. So the rapid deflation will make a drop in the left ventricle and the diastolic pressure, which will lead to reduction of the left ventricle and the diastolic pressure, and a reduction of the left ventricle preload. Regarding the changes of the coronary blood flow, the intra-aortic balloon, as we explored before, is able to increase the area under curve of the diastolic pressure time index. So this will increase the coronary blood flow, which will lead to increase the oxygen supply. And what are the changes in the left ventricle pressure volume loops? As you see here, this is the baseline, the dotted line is the baseline, and the red one is the pressure volume loops after assist of the intra-aortic balloon. As you see here, the curve of the afterload, or the point of the afterload, which is called end systolic pressure volume relationship, dropped from this point to this point. That means the afterload has been reduced. There is a change in the minimally change in the left ventricle in the diastolic pressure and left ventricle in the diastolic volume, and As we see that the balloon deflation will create negative pressure mechanics. And if we see that the BC limb, this is equal to the afterload, it has been reduced, which will lead to decreased left ventricle workload and the myocardial oxygen consumption. And during the isovolumetric contraction phase, the time for the isovolumetric contraction phase, which is from A point to P point, so it has been shortened by the intra-aortic balloon. So the left ventricle workload has been decreased, and the left ventricle oxygen demand has been decreased. And the stroke volume a little bit increased with the use of the intra-aortic balloon. What are the changes in the coronary blood flow? So the intra-aortic balloon improves the myocardial oxygen supply. This is well demonstrated by assessing the relationship between the diastolic pressure time index and systolic pressure time index. And this one we have explored before. So augmentation of the intra-aortic balloon increase the diastolic pressure time index compared to the unassisted waveform. This will lead to increase in the coronary blood flow. Changes in the cerebral blood flow with the intra-aortic balloon. The intra-aortic balloon is able to increase the cerebral blood flow, especially during the diastolic phase. And here in this article, it has been proved that the intra-aortic balloon has increased the cerebral blood flow in a patient with impaired left ventricle ejection fraction. And this has been confirmed also with the transcranial Doppler. And as you see here, this is a normal patient. And these are the pressure waveform during the transcranial Doppler. So this is the peak velocity, and you will get the diastolic phase, which is decreased here. And here, if we added intra-aortic balloon to this patient, so you will get, this is the peak velocity during the systole. And here you will get the diastolic augmentation with the intra-aortic balloon. So you will get more blood supply to the brain during the diastolic inflation of the intra-aortic balloon. So if we have an intra-aortic balloon, how you will be able to improve the intra-aortic balloon performance? There are many factors. If you control this factor, you will be able to improve the intra-aortic balloon performance. Factors related to the balloon volume, heart rate, balloon diameter, balloon position, balloon configuration, heart rate, and stroke volume, and the systolic vascular resistance. Regarding the balloon volume, the balloon, as we said, it should occlude almost 80 to 90% of the aorta. And if the balloon volume is equal to the stroke volume of the heart, ejected by the heart, this will maximize the diastolic augmentation. So if the stroke volume is almost around 50 ml, so if the balloon volume around 50 ml, so you will be able to increase the diastolic augmentation. But if the stroke volume is around 50 ml and you used a balloon like 30 ml, so you will not improve the diastolic augmentation for this patient because you will need a higher balloon volume. And the balloon diameter and occlusivity, and as we said, that you should occlude 80 to 90% of the aortic diameter if you are using intra-aortic balloon. So if you are not able to achieve this, you will get blunted diastolic augmentation, and the greatest augmentation occur with complete aortic occlusion. As we see here, this is the maximum occlusivity here. So you will achieve the maximum diastolic augmentation with this patient. So you will achieve perfusion to the brain, cerebral to the brain and the coronaries and distal perfusion. But if the balloon occlusivity is much less, so you will get minimal and decreased intra-aortic balloon performance. And the balloon position, the closer the balloon tip to the aortic valve, the greater the diastolic augmentation and the greater the diastolic pressure elevation. If the balloon is too much low, so the diastolic augmentation will be very less, and the balloon it will be helpless in this case. And regarding the balloon configuration, the augmentation of the intra-aortic balloon, ideally it should be set at 100%. If the augmentation of the intra-aortic balloon will set less, this will decrease the intra-aortic balloon performance. And if you have a problem with the intra-aortic balloon timing, so this will decrease the intra-aortic balloon performance, and this will be explored later on. And the stroke volume. If as we said, that the stroke volume and the intra-aortic balloon volume should be equal to each other. So if you have a low stroke volume, less than 25 ml, the diastolic augmentation will be less. The augmentation during the diastole basically depend in many factors, like the balloon volume and the stroke volume. So the volume inside the aorta, if it's less, the diastolic augmentation will be less. If the volume of the intra-aortic balloon low, so the diastolic augmentation will be low. If the patient is having vasoplegia and the aorta is becoming more redundant, so whatever the inflation of the intra-aortic balloon volume and size, so it will be useless and it will not improve the diastolic augmentation. The heart rate, as we know that the heart rate, the diastolic time is more longer than the systolic time, and if we increase the heart rate, the diastolic time will be shortened, and the intra-aortic balloon work mainly during the diastole. So if we shortened the diastolic time with tachycardia, so this will decrease the diastolic augmentation and you will not achieve your targets. So you have to keep your heart rate, if possible, the lowest, between 60 to 80. The pace is this targets, but in box up to 120, so the balloon can work. And with the auto mode, so the balloon will the system of the intra-aortic balloon will detect the proper timing in order to improve the augmentation for the patient, especially in patient with tachycardia, especially with AF. As I said, the systemic vascular resistance, it will affect the intra-aortic balloon performance. In cases of vasoplegia, the diastolic augmentation will be very less. And going to the next section, which is the indication of the intra-aortic balloon. These are the indication of the intra-aortic balloon: cardiogenic shock, acute myocardial infarction, high-risk PCI, acute mitral regurg, acute VSD, weaning from a cardiopulmonary bypass. And in patient with cardiogenic shock on VA ECMO, it can be used as a left ventricle venting strategy, especially in those patients with dilated left ventricle with cardiogenic shock. These are the contraindication for the intra-aortic balloon. There is absolute contraindication, which is the severe aortic regurg, aortic dissection, aortic stenting, and hypertrophic obstructive cardiomyopathy. The relative contraindication is the peripheral vascular disease, abdominal aortic aneurysm, and tachyarrhythmia. Evidence-based medicine, what are the clinical trials that has studied the use of the intra-aortic balloon in cardiogenic shock, especially complicating the acute myocardial infarction? We have many studies, but I think only 3 studies are positive. Regarding the most common the well-known study, which is the intra-aortic balloon shock 2 trial, which was published in New England Journal of Medicine in 2012. It was a negative trial, and there is no reduction of the 30-day mortality. But even after all this negative trial, the tertiary healthcare centers were still using the intra-aortic balloon in order to assist the failing heart. The next section is the device configuration. As we see here, this is the console of the intra-aortic balloon. The intra-aortic balloon device is divided into two parts. The console, as we see, this is the console for the intra-aortic balloon. And the second part is the connection connected to the intra-aortic balloon, which is the intra-aortic balloon catheter. And the console, as you see, you will have the touch screen and the display monitor, and you can see the heart rate, pressure waveform, and balloon pressure waveform. And the console, you will have a lot of touch buttons in order to set and adjust the setting of the intra-aortic balloon. And the second part, which is the catheter, as you see, the catheter is connected to a sheath, and the sheath is connected to arterial transducer, and the second part is connected to the helium cylinder, which is connected to a pump in order to inflate during the diastole and deflate during the systole. And this is the intra-aortic balloon catheter. As you see here at the tip, you will find a radio opaque tip, and after that you will find the balloon, and in the center you will find that this tube which is connected to the arterial transducer in order to trace the arterial blood pressure during the run of the intra-aortic balloon. So the intra-aortic balloons, there are many catheters, and the conventional intra-aortic balloon catheter, you will see port for connection of the helium and another port for connection to arterial transducer. And the new one, which is the fiber optic intra-aortic balloon catheter, you will find three ports attached to the catheter. The first port is transducer, arterial transducer, and the second port, which is the fiber optic catheter, fiber optic wire, which will continuously measure the arterial pressure waveform. And the third port is the helium. And as we see, the third port is the arterial pressure port, which can be connected to pressure bag with a Hapes line in order to maintain the patency of this one. Why we need the third port if you have the fiber optic? Because sometimes the fiber optic will not work. So you will be able to connect this one to arterial transducer, and you can trace the arterial pressure waveform. These are the charts for the intra-aortic balloon sizes, and this is the pediatric one, and this is the adult one, and the adult one is ranging from 34 cc, 40 cc, and the mega size, which is 50 cc. And this size is dependent on the height of the patient. As you see, the intra-aortic balloon is designed to sit in the proximal part of the descending aorta, and the balloon inflation and deflation, and the insertion site of the intra-aortic balloon. So the standard approach is the femoral approach. The intra-aortic balloon will be inserted through the femoral, common femoral artery, going to the iliac, then to the aorta, where it will sit in the proximal part of the descending aorta, above the level of the renal arteries and distal to the subclavian artery. And the alternative approach, which is the axillary approach, sometimes if you don't have access through the femoral artery, like patient with peripheral vascular disease, so you can put a graft in the axillary artery and introduce the catheter through the axillary artery, and you will introduce the catheter, so the tip, it will be above the level of the renal arteries, and the end of the balloon, it will be distal to the subclavian artery. What is the optimum intra-aortic balloon tip position? If you are using the standard approach, the radio opaque tip should be distal to the left subclavian artery, and the end of the balloon should be above the renal artery, and the opposite will be in the if you are using the axillary approach, the tip, the metal tip, should be above the level of the renal arteries. And the axillary approach, ideally, it should be confirmed position under fluoroscopy. And the femoral approach, you can rely on the chest X-ray. It should be ideally 2 centimeters above the level. Sorry for this mistake. The ideal position of the intra-aortic balloon, 2 centimeters above the carina, and also 2 centimeters distal to the left subclavian origin. And here in this chest X-ray, this is the optimum position of femoral approach of intra-aortic balloon. And this is the carina, 2 centimeters above the carina. And this is the axillary graft, introducing the catheter through the axillary graft down to the this proximal part of the descending aorta. And the tip ideally should be above the level of the renal artery. And the insertion technique, in this lecture, we are not introducing the insertion technique. So you can scan this QR code in order to see 3 videos of high quality of insertion technique of the intra-aortic balloon. Going to the intra-aortic balloon display monitor and touch screen, and we have, as we told before, you will get this reading and you will have this button in order to adjust the setting of the intra-aortic balloon. And this another device. It's different devices, but you will find the same setting and same reading in the display monitor. And to run the intra-aortic balloon, you will have different modes, which is called the operational modes of the intra-aortic balloon. You will have the auto mode, the semi-auto mode, and here you will have the manual mode. The manual mode is mainly used in the pediatric cases, and in adult, we are using mainly the auto mode. Because the auto mode will be able to detect the beast trigger for the patient, and this will can manage the patient, especially with tachycardia, arrhythmia. So it will give you the best inflation timing for the patient. So the auto operational mode, the machine will detect the beast trigger for the inflation and the beast trigger for the deflation, but the operator will be able to adjust the timing for the deflation in the auto mode, but the operator will not have the ability to adjust the timing for the inflation, because the inflation point will be detected, decided by the machine. And in the auto mode, the machine is able to manage the irregular rhythm, and the inflation point of the balloon will be detected, decided by the machine. In the semi-auto mode, if you activated the semi-auto mode, you will be able to select the trigger. So the operator will be able to select the trigger for the patient, for the intra-aortic balloon, and the operator will be able to have the access to control the inflation timing and also the deflation timing. And in this semi-auto mode, semi-auto because the machine is automatically able to manage the changes in the rhythm and heart rate. And as we say, the manual mode we are using only for the pediatric cases. And going to the intra-aortic balloon trigger. The intra-aortic balloon trigger, what is the trigger? The trigger, that is the signal that the machine use in order to know the timing for the systole and to know the timing for the diastole. If the machine know the start of the systole and the start of the diastole, so the machine will start the deflation and will start the inflation of the balloon. So the machine is able to know the time for the diastole, so it will start the balloon inflation. And if the machine is able to know the start of the systolic cycle, so the machine will give order to the balloon in order to start the deflation. Simply, this is the trigger. The trigger is the signal that the device use in order to identify the beginning of the cardiac cycle, which is the systole. So the balloon will start the deflation. The trigger, it might be ECG waveform, It might be arterial pressure waveform, and it might be like internal mode. It might be like using a based rhythm in order to identify the timing for the cardiac cycle, the timing for the systole, and the timing for the diastole. So to understand the IABP trigger here, the machine used the ACG in order to identify the trigger. So the software of the machine know that the R wave is the beginning of the systole. So at that time, the machine will start the deflation. And the software in the machine, if the machine able to detect the end of T wave or the late of T wave, so the machine will start the inflation, which is at the same time of the acritic notch. And if the machine used the arterial waveform in order to as a trigger in order to detect the timing for the cardiac cycle, so the machine will use the systolic upstroke in order to identify the beginning of the cardiac cycle. And in order to identify the beginning of the diastole, the machine will use the diacritic notch in order to identify the beginning of the diastole and inflation of the intra-aortic balloon. So different triggers the machine can use, like the ACG. So if the ACG is being used, so the trigger here, it will be the signal here, it will be the peak of the R wave, which is equal to the beginning of the systole. So if the machine identifies the R wave in the ECG, it will start the deflation because this is the timing for the systole. And if you use the pressure waveform in or as a trigger, so the machine will identify the systolic upstroke as a trigger in order to identify the systole, and this will initiate the balloon deflation. And also the machine is able to use the based rhythm in order to identify the signal in order to start the inflation and deflation of the intra-aortic balloon. And what is the internal mode? The internal mode is that the machine can set like a fixed heart rate, okay? And this fixed heart rate uh, like 80 beat per minute. So the machine can use it in order to start the inflation and the deflation. When the machine will use the internal mode, or the operator can use the internal mode, simply in case of asystole, like if you have a cardiac arrest, so you can move to the internal mode, and this will give you fixed heart rate like 80 beat per minute, and the balloon will start the inflation and deflation. And some patient with like asystole, like a patient on cardiopulmonary bypass, because they are having cardioplegia, there is no electrical activity in the heart, so the intra-aortic balloon will use the internal mode to give fixed heart rate to start the inflation and the deflation based on this fixed heart rate. So it could be between the 40 and up to 20 beat per minute, depending on the condition of the patient. And we see here that the patient is having paced rhythm, and the trigger that was set by the operator, it was the paced rhythm. But unfortunately, at some point, we lost the basing of the pacemaker, and as you see here, the machine till this point was relying on the basing of the pacemaker in order to inflate the balloon. But once you lost the base rhythm, the machine stopped the inflation. So this is very important if you are using the pacing as a trigger. So you have to make sure that the patient is having a paced rhythm 100%. So in case of loss of the pacing, you will not be able to inflate the balloon, and you will not be able to improve the hemodynamics for that patient. And the intra-aortic balloon timing is refer to the position of the inflation point and the position of the deflation point on the arterial waveform. So this is the normal graph of the intra-aortic balloon. So here at this point, this is the inflation point of the intra-aortic balloon here, the baseline. And here the intra-aortic balloon starts the inflation, and so we are calling this point the inflation point. And here the intra-aortic balloon starts the deflation, and we are calling this one the deflation point. So this is the inflation point, and this is the deflation point. Changes in the in the timing of the inflation point and deflation point will affect the performance of the intra-aortic balloon, and might be harmful to the patient. The intra-aortic balloon frequency, the frequency of intra-aortic balloon when you start it should be a 1-to-1 ratio. So each cardiac cycle is assisted by the intra-aortic balloon, and you can choose the ratio 1-to-2. So every second cardiac cycle is assisted with the intra-aortic balloon. And if you choose the ratio 1-to-3, so every third cycle will be assisted with the intra-aortic balloon. And if the patient is still requiring full support with intra-aortic balloon, you should go for 1-to-1 ratio. If the patient showing signs of recovery and became more hemodynamically stable and his heart is recovering, so you can start weaning of the frequency to 1-to-2 or 1-to-3 ratio, depending on the situation. This is an example for 1-to-1 ratio. So here each cardiac cycle is supported with intra-aortic balloon, and here 1-to-2 ratio, you see this cardiac cycle showing augmentation of the diastole. The next cycle is not assisted with the balloon. This one assisted, this one not assisted, assisted, not assisted. So this is 1-to-2 ratio. Going to 1-to-3 ratio, this cycle is assisted, this one and this one not assisted. This is 1-to-3 ratio. Usually we are using this 1-to-2, 1-to-3 as a weaning mode. Intra-aortic balloon augmentation. This is the percentage of the inflation of the intra-aortic balloon. So ideally, when you are starting intra-aortic balloon, it should be 100% augmentation, and the minimum augmentation should not be less than 70% because it will increase the risk of balloon thrombosis. So regarding the intra-aortic balloon augmentation, it might be reduced augmentation. So the reduced augmentation may be related to like patient factors related to the balloon configuration, and factor related to the catheter, factors related to the timing. All these factors, it might affect the performance of the intra-aortic balloon. Going to tachycardia, it will shorten the diastolic time, and it will shorten the diastolic augmentation. If you have a reduced stroke volume, so the diastolic augmentation will be reduced, and we have shown this before. And if the MAP less than 40, the balloon augmentation will be suboptimal. If you have vasoplasia, you will get very low diastolic augmentation. Factors related to the balloon, if you decrease the balloon augmentation, like if you decrease the augmentation to 70%, so this will reduce the augmentation of the balloon. And catheter factor, like if you have leak of the helium from the circuit, so this will lead to poor inflation and poor augmentation. If you have a king, so this will lead to poor inflation and also poor deflation, and will affect the augmentation of the balloon. And if the timing is not appropriate, this might affect the augmentation. Like if you have late inflation and or early deflation, so you will get reduced augmentation, and this will be discussed later. The next part is about the balloon pressure waveform. And as you see, these are the ECG, the arterial waveform, and this is the balloon pressure waveform. And this is the normal graph of the balloon pressure waveform. This is the baseline, and when the balloon starts the inflation, so this is the point of the start of inflation, you will get the inflation limb. Then the inflation limb, it will reach to the peak here, which is called the inflation overshoot. And after that, it will be for its transient, very short duration. Then you will reach to the drop to the plateau. What is the difference between this one and this one? When the balloon starts the inflation, so there is a pressure inside the balloon, and there is also pressure inside the aorta, and those forces are opposing to each other, and at the end you will reach to the state of equilibrium, which is demonstrated by the plateau. And at this point, which is the deflation point, the balloon will start the deflation and the pressure will start to drop. And the same also, the pressure inside the aorta and the pressure inside the balloon will be the pressure inside the balloon and the pressure inside the aorta will reach to the state of equilibrium at the end of the deflation. And the ideal filling pressure baseline is between 10 to 15 millimeter mercury. Sorry for the noise. Initiating the intra-aortic balloon. So when you put the catheter and you connect the catheter and all the connection to the device, you should put the intra-aortic balloon on and verify the helium supply, then connect the ECG source, connect the arterial pressure source, and then you will go to zeroing of the arterial pressure. Then you will connect the intra-aortic balloon catheter. Then you will check the operational mode. If it is the semi-auto mode, then you will go for selection of the trigger source. Then you will go for keeping the augmentation up to 100%. Then you will start the intra-aortic balloon. And after starting the intra-aortic balloon, you should assess for the appropriate timing. Then after adjustment of the timing of the intra-aortic balloon, then you will start the intra-aortic balloon again. After insertion of the intra-aortic balloon and running the intra-aortic balloon, so regularly you should have the patient assessment. And if this is the patient with intra-aortic balloon, so there is a lot of assessment to be done, like the vascular assessment. So you have to check the radial pulse, you have to check the pedal pulse, you have to check the insertion site, and also you have to check the tubes of the intra-aortic balloon, and you have to maintain the patency of the arterial line of the intra-aortic balloon with HIP saline, and you have to monitor the urine output for the patient. So why we are assessing the radial pulse? So the balloon, as we said, it is sitting in the proximal part of the aorta. If the balloon migrated up, so it might occlude the origin of the left subclavian artery, and you will not get a blood supply to the left upper limb. That's why you need to assess the radial pulsation. And the best approach to assess the radial pulsation is to put arterial line connected to the monitor of the patient in the left radial artery. So if you lost the waveform, that might alarm you that the intra-aortic balloon has migrated and encroaching the origin of the left subclavian artery. At that time, you need to adjust the intra-aortic balloon side. And you need to assess the pedal pulsation because the intra-aortic balloon is inserted in the common femoral artery. If you have a patient with peripheral vascular disease, you might not be able to get a perfusion to the distal limb. So regularly you have to assess the pulsations of the upper limb and lower limb by the Doppler, and each console will have a portable Doppler inside the box of the console. And also you need to assess the urine output, because the intra-aortic balloon, it might be migrated downward, and it might occlude the blood supply to the renal arteries, and you might have renal shutdown, and that's why you need to assess the urine output. The catheter tube, the tube of the catheter, you should assess the tube of the catheter, because if you saw blood inside the tube of the catheters, that means the intra-aortic balloon might be ruptured, and the blood will go inside the tube of the intra-aortic balloon. And in this situation, you have to stand by the intra-aortic balloon and prepare for balloon removal. So this is the daily assessment for the patient with intra-aortic balloon. And if we have a patient with cardiogenic shock, so we have aim of the treatment. What is your aim of treatment of a patient with cardiogenic shock? You have to maintain the circulatory support, and you have to unload the left ventricle, and also you have to maintain the coronary perfusion. And in order to support the circulation, you will have a target map, and you will have a tool. And the tool, in order to maintain the circulatory support, it might be vasopressors, might be inotropes. You might go for mechanical circulatory support like intra-aortic balloon, ECMO, or Impella. And the second aim is left ventricle unloading, and you are targeting reduction of the left ventricle pressure and left ventricle volume. You can achieve this by applying medical therapy like diuretics, inotropes, or with the aid of the mechanical circulatory support like intra-aortic balloon or Impella. And during that, you can monitor the patient with echo and pulmonary capillary wedge pressure. And the third aim is to maintain the coronary perfusion by increasing the diastolic pressure time index and subendocardial viability ratio. And the tool for that, to maintain the coronary perfusion, is either to have to do PCI, or to maintain the MAB and the diastolic pressure, diastolic blood pressure. And you can go for the intra-aortic balloon in order to maintain the coronary perfusion. Going to the next section, which is the intra-aortic balloon troubleshooting. You will have a lot of sections for the troubleshooting, like timing errors, augmentation errors, balloon pressure errors, and if you have a patient with intra-aortic balloon with tachycardia, what about the intra-aortic balloon during the CPR, if you have a cable connection, arterial line malfunction, and if you have balloon rupture. So going to the first section, which is the timing errors. So the timing of the intra-aortic balloon, you have inflation timing errors and you have deflation timing errors. Both, it might be early and might be delay. You might have early inflation or late inflation. You might have early deflation or late deflation. So how to assess the timing? So ideally, when you start the intra-aortic balloon, you put the balloon on ratio 1:1. In order to assess the timing errors, you have to put the intra-aortic balloon ratio 1:2. You have to compare the assisted waveform with the unassisted waveform. And after that, you will apply 3 reference lines. The first reference line is here. You will put the reference line at the level of the diacritic notch of the unassisted waveform. And if the inflation point is at the same time, at the same level of the diacritic notch, that means the inflation timing is perfect. And also the second reference line, you have to put it at the level of the unassisted systolic pressure, and you have to compare the level of the unassisted systolic pressure compared to the level of the assisted systolic pressure. And normally, the assisted systolic pressure should be at a lower level than the unassisted systolic pressure. So this is perfect position of the assisted systolic pressure. And the third reference line at the level of the unassisted end diastolic pressure, and normally you will have the assisted end diastolic pressure lower than the level of the unassisted end diastolic pressure. So this is how to assess the timing errors. Put the patient, the balloon into 1:2 ratio, apply the reference line, check the level of the diacritic notch to compare the level of the diacritic notch to the inflation point, and compare the assisted pressures to the unassisted pressures. So the first timing troubleshooting is the early inflation. And as we said, you have to put 1:2 ratio. So the first reference lines is the at the level of the diacritic notch of the unassisted waveform. So you will put the reference line here at the level of the diacritic notch, and you will see the inflation point. And as you see here, the inflation point is above the level of the diacritic notch. Meaning what? Meaning the inflation happened earlier. Meaning the inflation happened earlier. It was supposed to happen here, but it happened here. That mean what? At this point, the aortic valve is still closed. At this point, the aortic valve is still closed, but at this point, the aortic valve is still open. So the diastolic augmentation happened during the systolic phase where the aortic valve is still open. So what will be the consequences? It will start the inflation of the balloon and will start the diastolic augmentation. So this will lead to augmentation of the diastole while the aortic valve is still open. So what will happen here is that you will have aortic regurgitation. The blood inside the aorta will be displaced inside the left ventricle because the aortic valve at this stage is still open. So this will lead to aortic regurgitation. And also this will lead to increase in the left ventricle and the diastolic volume, left ventricle and diastolic pressure, and consequently this will lead to increase in the pulmonary capillary wedge pressure. And if we increase the left ventricle in the diastolic volume and left ventricle in the diastolic pressure, this will lead to increase in the left ventricle wall stress, and this will lead to increase the oxygen demand. Like that, you are not helping the failing heart because you are applying resistance against the failing heart during the systole. So this is the early inflation for intra-aortic balloon with 1:1 ratio. As you see here, the inflation happened very early. So this will lead to aortic regurgitation, increase the left ventricle and the diastolic volume, increase the left ventricle and the diastolic pressure, and this will lead to increase left ventricle stress and increase oxygen demand by the heart. Going to the next one, which is the late inflation. So again, put 1:1, apply the reference lines to the diacritic notch of the unassisted waveform. So you have to compare the level of the diacritic notch to the point of the inflation. So as you see here, the point of inflation, it happened after the diacritic notch. So that means there is delay in the inflation, late inflation. So what will happen if the inflation happened late? So the balloon will start the inflation and it will reach to the maximum, but the diastolic augmentation will be reduced. So what will happen if the diastolic augmentation will be reduced? So the diastolic blood pressure will be less, and the coronary perfusion, it will be less. So what you will get suboptimal coronary perfusion of the failing heart, especially if it's having acute myocardial infarction. So this might lead to ischemia to the patient. And as you see here, so you will get this is the late inflation of a patient with intra-aortic balloon, but this is 1-to-1 ratio. So the notch here is wide, and the dichrotic notch is here, but the inflation point is here, and the diastolic augmentation is less than the unassisted systolic pressure. And this will lead to suboptimal coronary perfusion. Going to the next timing abnormality, which is the early deflation. What is the meaning of early deflation? The inflation of the intra-aortic balloon should continue throughout the diastolic time. So it will maximize the diastolic augmentation, and it will maximize the coronary flow. So what will happen if the balloon started the deflation earlier? So the timing for the diastolic augmentation will be less, and the coronary perfusion, it will be suboptimal. The timing for coronary perfusion will be suboptimal. But as you see here, the intra-aortic balloon started the inflation here. The inflation point, it was at the same level of the dichrotic notch. Inflation is fine, perfect. Diastolic augmented pressure is higher than the unassisted systolic pressure, which is okay. Then the balloon started to inflate diastolic augmentation. So this will lead to increase the coronary blood flow to the coronaries, but it was supposed to be inflated for longer duration, but unfortunately the deflation started very early, so this will lead to a rapid drop of the pressure waveform. So you will get rapid drop on the pressure, and this might lead to this rapid drop of the pressure. This will decrease the pressure inside the aorta suddenly, and this might lead to, instead of the coronary blood flow going to this direction, so it will suck the blood back to the aorta. So we will get what is called retrograde coronary perfusion and what is called the coronary steal phenomena. So with diastolic augmentation, you will get suboptimal coronary perfusion, and if the early inflation happened very fast, so you will get reversal of the flow in the coronary, so you will get retrograde coronary perfusion and what is called the coronary steal phenomena. Regarding the pressure changes with early deflation, so you will get the assisted endodiastolic pressure, it could be at the same level of the unassisted endodiastolic pressure, and also the assisted systolic pressure will be less, will be almost at the same level of the unassisted systolic pressure. So the physiological effect of the early deflation will be suboptimal coronary perfusion. You might have retrograde coronary perfusion and carotid blood flow. You might have angina because of coronary steal phenomena, and you will get suboptimal afterload reduction because the early inflation, the deflation, it should happen at the systole, but this early deflation happened during the diastole. So the afterload reduction during the systole, it will be decreased, and it will be suboptimal. And at the end, you will get increased oxygen demand because the afterload reduction was suboptimal. So this will increase the oxygen demand. And to understand the coronary steal phenomena, so this is the intra-aortic balloon inflated during the diastole. So the blood here in this column, it will be displaced towards the carotid, and also should be displaced during to the coronary. At this point, which is the diastole, the aortic valve is closed. So what happens if the aortic valve is still closed and the intra-aortic balloon started early deflation? So the pressure here in the aorta will drop and you will get reversal of the flow because the aortic valve is closed. So the blood going to the carotid and the blood going to the coronary will be have the reversal of the flow, which is called coronary steal phenomena. And this patient might develop angina and might have ischemic event. And like that, you are not helping the failing heart secondary to acute myocardial infarction. And this is the graph of the early deflation. If you have intra-aortic balloon with ratio 1:1, what is obvious here is that the inflation time is short, but the deflation time is more prolonged. And as you see here, this is the inflation of the intra-aortic balloon, but this is the deflation time for the intra-aortic balloon. So here, instead of being like this, then being like this, so the deflation time is more prolonged and you will have this wide notch. The last timing errors, which is the late deflation. What is the meaning of late deflation? So the intra-aortic balloon ideally it should start the inflation, start the augmentation, then the inflation should be till the diastolic time, and the inflation should end at the beginning of the or before the beginning of the systole. So what will happen if the deflation of the intra-aortic balloon became very late? That means the deflation of the intra-aortic balloon happened during the systolic phase, meaning the deflation of the intra-aortic balloon happened after the aortic valve opening. So this will mean that you will have very less afterload reduction, and the oxygen demand for the heart will be increased because the left ventricle, the aorta is opened and the left ventricle is trying to eject the blood while the balloon still inflated. So this will lead to increase afterload reduction. It will be absent. In the opposite direction, the intra-aortic balloon, it will work as a force against the heart during the systole. And actually what's happening here is that you are increasing the afterload by continuing inflation of the intra-aortic balloon during the systolic cycle. So this will increase the workload by the heart, and this will increase the oxygen demand by the heart in order to overcome the greater resistance by the balloon inflation. And as we see here, the prolonged inflation of the balloon and late prolonged deflation of the balloon. So this will lead to elevation of the assisted end diastolic pressure above the level of the unassisted end diastolic pressure, and this will lead to elevation of left ventricle end diastolic pressure and left ventricle end diastolic volume. So the left ventricle stress volt will be increased. And this is the graph for the late deflation in intra-aortic balloon with 1:1 ratio. And if you have a troubleshooting with the timing, so how you will go for the timing adjustment. So basically, if you are in the auto operational mode, you will have access only in order to adjust the timing for the deflation, but you will not have the ability in order to adjust the timing for the inflation. So you have to go to activate the semi-auto mode. If you activated the semi-auto mode, you will be able to adjust the timing for the inflation and also adjust the timing for the deflation. And to adjust the timing for the inflation, if you have early inflation, so you have to press this button to move the inflation point to the optimum point. And if you have a problem with the deflation, like late deflation, so you have to activate this button, move this button, press on this button in order to adjust the deflation point. As you see here, this is the inflation deflation timing in auto mode. Here in the auto mode, the inflation timing is not accessible by the operator, but the deflation timing is accessible by the operator. Once you switch from the auto mode to the semi-auto mode, the operator will have the access in order to adjust the timing for the inflation and the deflation. So we will have this troubleshooting for the time adjustment. So this is a normal patient with optimum timing. And this is a patient with early inflation, as you compare. This is the reference line. This is the diachrotic notch, and this is the inflation point. It happened very early. And as you see here, the inflation timing here is very early. So you just go to adjustment for the inflation timing button and move it forward to reach to this point to adjust the timing to bring the inflation point here. And this is a patient with late inflation. As you see, this is the point for the diachrotic notch, but the inflation point instead of happening here, it happened late, so the notch is wide here. So what you need to do is to move the point inflation from this point to this point in order to adjust and optimize the inflation timing. And what you see here is early deflation. As you see here, this white gap is diagnostic for the early deflation. And what you have to do is this is the deflation timing. So you have to move the point of the deflation from this point to this point in order to optimize the deflation timing. This is an example of late deflation. So as you see here, this is very late deflation, and you need to move the point of the deflation from here to here in order to optimize the timing for the deflation. The next troubleshooting is about the reduced intra-aortic balloon augmentation. So normally, if you have an intra-aortic balloon, so this is the diachrotic notch. So the balloon supposed to start the inflation here to reach to the diastolic augmentation here, and the diastolic augmentation pressure should be higher than the unassisted systolic pressure. But if you have a problem with the timing, if you have many problems that can affect the augmentation, so the augmented diastolic pressure might be reduced than the unassisted systolic pressure. And this is what we are calling reduced intra-aortic balloon augmentation. So there is a lot of factors, factors related to the patient, like if you are having tachycardia, reduced stroke volume, reduced mean arterial blood pressure, and vasoplegia. And all these factors I think we have discussed before. And the balloon factor, like if you decrease the augmentation of the balloon to 80%, 70%, so you will get reduced intra-aortic balloon augmentation. Catheter factors, like if you have a leak from the catheter, so you will get a poor inflation and you will get reduced augmentation. If you have a kink in the catheter, so you will get a poor inflation and poor deflation also, and both will affect the intra-aortic balloon augmentation. The last factor is the timing factors. If you have late inflation, like this patient is having late inflation, so the diastolic augmentation will be suboptimal, and it will be less than the unassisted peak systolic pressure. And also, if you have early deflation, the augmentation timing will be less, and you will get reduced intra-aortic balloon augmentation. Going to the next section for the troubleshooting, which is the balloon pressure waveform abnormality. So this is the normal balloon pressure waveform graph: inflation limb, deflation limb, inflation point, and inflation overshooting, plateau, inflation plateau, and the deflation overshooting, and the baseline, the filling pressure baseline, which should be at the level of 10 to 15 millimeter mercury. And the first abnormality, that your baseline may suboptimal. So the baseline of the filling pressure baseline may be less than 10 to 15% millimeter mercury. So this happen if you have like disconnection of the helium pipe, or if you have a leakage of the helium, or if you have a balloon rupture, so you will not get any pressures. And the second abnormality is that your filling pressure baseline is above the normal. So this may be due to manufacturer error. So when you inflate the balloon, you will get elevated filling pressure above the baseline, or it might happen if your catheter is kinked. So the baseline pressure of the balloon pressure, it will be over the higher than the normal level. And you will have two abnormalities regarding the plateau. So the first abnormality is that you have low plateau pressure. So this is the inflation limb. Then you will get the inflation overshooting. Then shortly after that, you will get the plateau, supposed to be at this level. But if the level has been reduced markedly to this one, you might have many issues, like if you have severe hypotension, severe vasoplegia, very low stroke volume, and you might have a very small balloon, like 34 cc instead of 40 cc, or the balloon positioning is very high or too low. And you might lose the plateau. So this is the inflation limb. You should have the inflation overshoot. If you have inflation overshooting, that means you are losing the plateau. So you lost the plateau. So you should have the inflation overshoot, then you get the plateau. So this shape is that might happen due to if you have a very big balloon, so the inflation of the balloon very high, and if the patient is extremely hypertensive, or if the balloon is very high in the aorta, or you might get this simply because the intra-aortic balloon is kinked, like this one here. As you see, this is the normal waveform of the balloon pressure waveform, overshooting, plateau, then deflation, deflation overshooting, then you will go to the baseline. So what happened here is that we kinked the catheter, and as you see, you will lose the plateau. This is the plateau, you will lose the plateau, as you see here. The next troubleshooting, which is related to the balloon pressure rupture. So as we say, during the assessment, you have to check the tubing of the catheter, which is connected to the catheter. You can see that the tube is full of blood. In this situation, you have to stand by the machine and remove the catheter. Here, as you see, that when they remove the catheter, there's a blood inside the balloon. That means this balloon has been ruptured. So what is the evidence of rupture? You can see blood in the helium tubing, and you will see that intra-aortic balloon failure, sudden patient hemodynamic instability. You will get also the console for console alarm. What action you should take? You should support the patient with hemodynamics, support hemodynamics of the patient with vasopressors and inotropes, stand by the intra-aortic balloon, clamp the helium line in order to prevent gas embolization, and you should remove the intra-aortic balloon or change the intra-aortic balloon over guide wire. Going to the next troubleshooting, which is the intra-aortic balloon arterial line malfunctioning. So simply the fiber optic of the intra-aortic balloon, it might be damaged, and you will not be able to get the pressure waveform. So in this situation, if your fiber optic is not working, so you have to connect the arterial board here to a transducer, and you will connect the cable to the back of the console here, and then you will get the arterial waveform. So in this console, you have a board for the fiber optic to measure and trace the arterial waveform. But if it's not working, you have a backup here board for arterial line. And if you used this one, you have to go to the sources, and after that it change from the direct to the external source, which is this port for the arterial line. Troubleshooting of the intra-aortic balloon during the CPR. So if you have a patient with intra-aortic balloon and you have a cardiac arrest, so you can do the CPR while the balloon is working. And it has been proven that the intra-aortic balloon to be very efficient and very helpful to improve the outcome of the cardiac arrest if it was working simultaneously with the chest compression, as you see here in this article. So what will happen, what you should do during the CPR with intra-aortic balloon? So the first thing is that you have to change the trigger. So if you are in the auto mode, you should activate the semi-auto mode, and you should go to the trigger to arterial waveform, the arterial pressure trigger during the CPR, because in the auto mode, the most commonly used one is the ECG, but during the cardiac arrest, you will lose the core electrical activity. So you have to convert from the ECG trigger into the arterial pressure trigger. So during the chest compression, the machine will sense the changes in the pressure and will use the systolic upstroke as a trigger in order to start the balloon deflation. And if the console is not able to recognize the arterial pressure, you have to apply high quality CPR. And if you did this and you're still not, the console is not able to recognize the trigger, so you can in this situation put the balloon in the standby mode, but not for longer duration because of the risk of the thrombosis. And during the cardiac arrest, it has been written in the publication that you should set the augmentation to 50% during the CPR. So during the CPR with intra-aortic balloon, you should put the augmentation of the percentage of the intra-aortic balloon down to 50% during the application of the CPR. And regarding the defibrillation, if your patient is an intra-aortic balloon, you can deliver the defibrillation safely with intra-aortic balloon. What about the intra-aortic balloon and tachycardia? So as we discussed before, that there are different factors that improve the intra-aortic balloon performance, and one of these factors is the heart rate and the rhythm. So if you have a tachycardia, so you will get shorter cardiac cycle, and you will get consequently, you will get shorter diastolic time. and you will get shorter diastolic augmentation, and the area under curve of the diastolic pressure time index will be decreased. So the coronary perfusion will be decreased and the oxygen supply to the heart will be decreased. So if you are having tachycardia with intra-aortic balloon, you will get suboptimal coronary perfusion and you will get decreased oxygen supply, and also you will get suboptimal diastolic augmentation, and you will have also a hemodynamic effect. And as we see here, to understand the effect of tachycardia, so this is the normal timing for the balloon inflation in a patient with normal heart rate. And this will be the inflation timing of the balloon during the tachycardia. As you see here, the diastolic time is much prolonged, and here the diastolic time is much shortened. And as you see here, this is a patient with not tachycardic heart rate is 82, and the same patient, she had heart rate about 130. The diastolic augmentation here is perfect, and here the diastolic augmentation is blunted. Same also, this patient heart rate here is much less, but here the patient is having like runs of VTAC. So the diastolic augmentation here is perfect, but here the diastolic augmentation is very less, and this will lead to hemodynamic compromise and suboptimal coronary perfusion. And the same also regarding the AF, you will get shortened diastolic time and shortening the reduced diastolic augmentation. So if you have a patient with arrhythmia or tachycardia, this might lead to reduced intra-aortic balloon performance. So you should consider optimizing your inotropes, which might increase the heart rate and might increase the arrhythmia. And you should consider cardioversion and rate control medication in order to decrease the heart rate to optimize the intra-aortic balloon performance. And also, if the patient is awake, agitated, so you can consider the sedation in order to decrease the sympathetic activity and decrease the heart rate a little bit. And we showed this one before. The heart rate will affect the duration of the diastolic perfusion time index, and consequently the coronary supply and the oxygen supply to the heart. Going to the next section, which is the complication of the intra-aortic balloon. Many complication, vascular complication, mechanical complication, and life-threatening complication. Vascular complication including limb ischemia, systemic embolization due to cholesterol or helium, bleeding at the insertion site, thrombocytopenia. You might have stroke due to cholesterol embolization. Mechanical complication like balloon rupture, leak, and balloon migration. Sometimes you have balloon entrapment, and sometimes if you have a problem with the timing or augmentation, you will get suboptimal augmentation, suboptimal inflation timing. You might have clot in the pressure line. You might have distortion of the pressure line, and life-threatening complication like the aortic dissection, aortic rupture, and sepsis, which might be related to catheter-related bloodstream infection, which might be fatal in some patients. The next section is the weaning of the intra-aortic balloon. In order to start the weaning, you have to fulfill the criteria for the weaning, which is the improved cardiac output and hemodynamic stability and minimum hemodynamic support. So what are the weaning modes? So there are different weaning methods. The common approach, which is the weaning assist ratio. So this is the assist ratio 1 to 1, 1 to 2, 1 to 3. So you are weaning from 1 to 1 to 1 to 2, then 1 to 3. So this is the commonest approach. And the less common approach, which is weaning the assist of the augmentation. So instead of augmentation 100%, we'll go to 90, then 80, then 70, and the least augmentation percentage that should be used, which is the 70%, because below the 70%, the risk of the balloon thrombosis is increased. So if we went to the weaning mode, which is a weaning the assist ratio. So first we have to fulfill the criteria of weaning readiness, and you have to ensure weaning readiness. After that, change the ratio into 1:2 ratio. For 30 to 60 minutes, you have to monitor the patient for any signs of deterioration like hypotension, tachycardia, hypoxemia, and arrhythmia. Then you can shift, if the patient is stable, you can shift to 1:3 ratio. Then you will monitor the patient again for 30 to 60 minutes for any signs of deterioration. If the patient is deteriorating, you can proceed for the intra-aortic balloon removal. This is the most common approach. The other approach, you can go for weaning the augmentation assist. So first fulfill the criteria of weaning readiness. Then you can decrease the augmentation gradually and monitor the patient gradually till you reach to 70%. Then if the patient is tolerating, so you can go for intra-aortic balloon removal. Going to the last section, which is the removal of the intra-aortic balloon. So prior to removal of the intra-aortic balloon, most of the patients, they are using heparin infusion. So we should stop the heparin for almost 3 hours prior to removal. And the ABTT should be less than 50%. In order to decrease the ABTT should be less than 50 in order to reduce the risk of the bleeding. And during this period, you should start the weaning process of the patient. The most of the devices, the maximum ratio is 1:3, but there are some intra-aortic balloon devices you can go to ratio up to 1:8, but it's not recommended to increase the ratio more than 1:4, because this will increase the risk of the thrombosis of the balloon. And the assist frequency should be returned to 1:1 for 5 minutes every hour if the ratio is less than 1:3. And the patient should be positioned flat, and the balloon catheter is removed, and after which the pressure should be applied for at least 40 minutes. Usually we are using a device which is called femostop. This like pressure device, it will be applied at the site of the puncture of the cords for the catheter. So should be applied for 40 minutes until the bleeding stopped. And after that, you have to monitor the patient after the removal. Each 30 minutes, you have to check the hemodynamics, you have to check the other factors of any signs of any deterioration. And the site of the removal, you have to check if any signs of bleeding or hematoma every half an hour for 4 hours. Then second hourly for 8 hours until the patient start mobilization. If the bleeding recur, the position of the patient, position the patient in the flat position and apply firm pressure to the site.